Hello. Okay, so again, this is a video that is part two of our entire discussion on health policy and the role of government. This video is on how should healthcare provision be regulated. Okay, yeah. So we've talked about how should health insurance markets work, how should moral hazard be controlled, and now we're going to talk about how should healthcare provision be regulated. So far, we focused on cost controls and reducing moral hazard. So, in other words, we focused on what tools we can use as policymakers to shape the demand for healthcare, right? Now, we're going to turn to the other side of the system, how to regulate the provision of care itself. Because even if insurance is well designed, an unregulated healthcare market can still produce inefficiency, inequality, and runaway costs. So the big question here is, how should healthcare provision be regulated? Remember, even when people have insurance and access, the way that care is produced or who provides it and how it's priced or how it's organized plays a huge role in determining both cost and quality. So in this section, we're going to look at how governments can step in to regulate or even directly manage healthcare markets. And we're also going to, of course, talk about the trade-offs that come with doing so. So let's start by reminding ourselves of the core problem that arises when healthcare markets are left mostly private. First, we'll see something like oligopoly pricing, right? Where a small number of hospitals or provider networks dominate a region, and this then empowers them to set high prices. So the second problem that can arise when healthcare markets are left most to like the private market is we'll see monopoly rents, right? And this means that highly specialized doctors or hospitals can charge well above what a competitive market would allow. So the third issue we'd see is the medical arms race. And this is where hospitals compete to buy the latest expensive technologies to attract patients, even if those technologies don't actually improve outcomes. And finally, we would and could see physician-induced demand, where, as we know, doctors recommend more care than might be medically necessary, partly because they would benefit from doing so financially. So the real policy challenge is figuring out how to fix these problems without introducing new inefficiencies that are just as bad or worse. Broadly speaking, governments have three main ways to intervene here. So one option is public provision. And this is where hospitals and clinics are publicly owned and operated, such as the case with the UK's NHS or National Health Service. So another is private hospital markets, and this is where care is delivered by private institutions, but regulated through competitive oversight. And then finally, we could have a situation where governments set prices. And this is where the state allows private provision of care, but it controls what providers can charge for services. And we see this in places like Japan or France. So each of these strategies tries to strike a different balance between efficiency, fairness, and political feasibility. And this is the same theme we've seen running throughout this entire lecture. So our first model that we're going to discuss is public provision. And this is a model where we see a fully government-run system where hospitals are financed by taxes and physicians are essentially government employees. So the main argument in favor of a public provision model is that it can reduce cost and improve coordination by eliminating market inefficiencies. So if the government owns the hospital, you don't have to worry about oligopolies competing to drive up prices, or you don't have to worry about hospitals overspending to one up each other with expensive new technology, right? Of course, though, there are criticisms of public provision. So some argue that nationalized systems tend to be less efficient because government employees have weaker incentives to innovate or respond quickly to performance issues. In other words, when there's no real competition, critics would say, and hospitals can't easily go out of business, right? The threat of going out of business isn't, perpetually under or in the purview of the hospital. There's less pressure to improve, again, as the theory says. So, also in public provision, feedback mechanisms like profit loss or patient exit don't operate the same way as they do in private markets. So again, critics would say without those kinds of mechanisms, you would endure many inefficiencies in a publicly provided model. Empirically, though, we actually see that countries with nationalized systems like the UK or Sweden tend to do a better job of controlling overall healthcare costs. So where they struggle is on quality and the timeliness side, the timeliness of care side. The most common complaint in these systems is that publicly run hospitals can lead to long wait times and sometimes provide what is perceived as lower quality care. So public provision tends to excel in equity and cost control, but it's at the expense of speed and consumer choice, right? So it's like a classic efficiency versus equity trade-off that runs through nearly every policy model that we've discussed. Okay, the second model we'll talk about is private provision. And this is where hospitals and providers compete for patients. The advantage here is that competition can drive efficiency, right? Hospitals have strong incentives to operate effectively and improve service quality and in doing so would attract patients. But the challenge is balance, of course. Too little competition can lead to monopolies and high prices, but too much competition can trigger a medical arms race where hospitals overspend on prestige technology or luxury facilities to attract patients, which ultimately drives up costs rather than lowering them. Another key issue in private markets and private provision is, of course, equity. Competition doesn't guarantee access. And in this model, the poor or uninsured are the ones to fall through the cracks, and often do. So policymakers have tried to address this in a few ways. So for example, by offering tax breaks to nonprofit hospitals that treat low-income patients, or by requiring hospitals to provide emergency care regardless of ability to pay. So private provision can encourage innovation and responsiveness, but only if the government steps in to make sure care remains accessible and not just a profit-inducing endeavor. A third approach, and the final one we'll talk about today, is government set prices. And this is where governments don't run hospitals, but they regulate what providers can charge. So the goal in this kind of regulation is to prevent private hospitals from exercising market power and to keep care affordable. So in theory, this can contain costs, but price setting can also create distorted incentives if done poorly. So for example, if a service is priced below its cost, hospitals may stop offering it. Because it wouldn't be financially feasible for them to do so. Conversely, if something is priced too high, it might be overprovided. And the success of this system depends on getting the price right. So it depends on balancing fairness, efficiency, and sustainability in how care is valued and delivered. So to sum up, each of these systems tackles the same core problem. How do you provide quality care efficiently and fairly? Public provision controls costs, but the risk is in that system is inefficiency. Private markets, on the other hand, encourage innovation, but they can leave people behind. And when governments set prices, they try to strike a balance, though it depends on precise calibration, right? So in the end, most countries blend these models and combine public oversight with private delivery because no single approach perfectly reconciles the tensions between cost, access, and quality. So thank you for joining me on this journey. We have one more video in this lecture series on healthcare in different countries. See you there.